This morning on Monday, Sierra Leone joined the rest of the world to commemorate World Health Day. The day is celebrated each year on 7th April, marking the founding of the World Health Organization (WHO) in 1948. It's also dedicated to raising awareness about critical health issues facing the world and mobilizing efforts to address them. It serves as a pivotal moment to reflect on the health challenges that persist globally and the strides made towards improving health outcomes. It also provides an invaluable opportunity for stakeholders at all levels to come together and advocate for effective, sustainable health policies and practices, among other things. So this morning, to talk about the World Health Day and health in general, we do have the Minister of Health, Dr. Austin Demby. Good morning and welcome.
Good morning. Good morning to you and to your listeners and viewers.
So the theme for this year's, commemoration has a lot to do with maternal and newborn health. Now, how does that resonate to, the context of Sierra Leone when we talk about the realities on ground with maternal and child health or neonatal health? Is there any improvement or are there any concerns?
I just came back from Kigali, Rwanda, where a lot of ministers of health were convening. As you know, we have very, very steep headwinds around global financing around the world, but also specifically for health. And we were just roundly applauded in Sierra Leone for the focus we have on maternal and child health. As you know, we had dropped maternal mortality from one of the highest in the world. When you measure it, it was something like 1,300 per 100,000 live births. This is the highest. The closest to Sierra Leone was about 900 per 100,000 live births. We've dramatically reduced that from 1,300. Around 2018, it came down to 717. Around 2022, it came down to 443. Yesterday, we were so proud to announce that we dropped it even further from 443 to 354. Such a drop usually takes countries 10 years to accomplish. This dramatic drop that we've seen occurred in only about 8 years. So we're proud, we're very, very happy of the progress that's been made, but it's not enough because the president's mandate to us is to have zero preventable maternal deaths and zero preventable child death. So for us, we're happy if you compare us to other countries, but we're not in the business of working towards averages. We're not comparing ourselves to anybody. We're setting our own internal goals and working towards it, and we're in the right trajectory.
The reduction to 354 deaths per, is it 100 live births?
100,000.
100,000 live births. What do we attribute that to?
So it's a combination of factors. First, we have invested very, very well in what are called basic obstetric care services. We've also invested in comprehensive obstetric care services. We've invested in training midwives and nurses to offer services. We've created facilities that will be able to help women deliver safely. But most importantly, we've engaged the public, we've engaged the community, we've engaged the leaders. And so a lot of the credit that we have today really goes to the leaders, the women, the husbands who see the value in engaging with healthcare systems fairly early in their pregnancy. And we're committed to work with them to receive the kinds of results that we have. We're also looking at referral networks to ensure that if you have more complex cases, we identify them early and refer them to higher level care. It's a work in progress, but I think we're moving in the right direction. A couple of months ago, the whole Liberian Ministry of Health, the minister, all of the deputy ministers, all of the directors in the country came by road to Sierra Leone to see what we were doing, and they were very, very impressed. So again, we're not there yet, but we're moving in the right direction.
And among the data that you've just referenced, what is the contribution for rural areas? Because it's knowledgeable or known around that one of the hardest hit areas when it comes to health is the rural areas, taking into consideration maybe road networks, and the knowledge around there is more traditional and not heavily dependent on maybe modern medicines and practices.
Yeah. So what we've seen in Sierra Leone is a comprehensive reduction, major reduction in these urban areas, in the rural areas. But you're right, the level of reduction that we've seen in the urban areas is not reflected in what you see in remote rural areas. But the other day we had somebody deliver quintuplets in a remote area. So what we want to do is to intensify the effort on a national scale. We're very lucky in Sierra Leone because the country is round, the country is small, east to west, north to south is 7-8 hours maximum. We've got 16 distinct districts. So what we want to do is to decentralize the effort. First, create national standards that we will work towards, and decentralize and work in every district, every corner of the country to ensure that we get the kinds of results. And by the way, we just developed a new tool, Press Track. The Chief Minister fondly calls it Kumbra app. The Kumbra app allows us to register the pregnancy at first encounter. And after that registration, we have a commitment to co-own that pregnancy, the healthcare workers and the community. And we have a commitment to ensure that all services provided for that pregnant woman to ensure she remains healthy and delivers safely is our joint responsibility.
Is it still part of the free healthcare?
It is part of the free healthcare system. I think with this tool we've worked in about 2 districts to start it off, and we have ourselves the next 18 months to go national. Every other country in Africa is asking us for this tool. So, and it was homegrown, it's done with DSTI and the Ministry of Health, and it's going to what we call revolutionary in a way, because I think what we've done is by the way, the results that we shared yesterday was for 2023. You haven't even seen the 2024, 2025 results yet. I mean, it's been depressed even further. But what we have is these tools are what you call game changers. It changes the trajectory completely. We've set ourselves a target of 2030. We don't want to glide into 2030. We want to bend the curve quite dramatically. And this is one of the tools that we're using. Also, we're not going to leave this to chance. If you have time, we have an emergency operations center, a situation room that we've created here in New Englandville. And what we do is we look at the whole country. We monitor the whole country. We monitor every pregnancy. If there is a normal pregnancy, we have a complete profile of the pregnant woman, and it's reflected as a summary green dot. If there's a potential complication, for example, you have high blood pressure, diabetes, or pre-existing conditions, it's a yellow dot. If we lose a patient, it's a red dot. It's monitored in real time throughout the whole country so that you know where the greens are. You know where the yellows are, where they're clustered. So you know how to provide services to the yellows to ensure that either they remain yellow or they become green. If we lose any pregnancy, we detect it right away up here, and they detect it at the district level. And what we do is we do a thorough audit. What went wrong? People die naturally, but what we're saying is we don't want anybody to die of something that's preventable. So we want to focus on every case with the understanding that if we understand what went wrong, we'll be able to protect the yellows, we'll be able to protect the greens. So it's a national effort. Almost every morning they go out and check and see what's going on, and we're able to deploy resources accordingly. This is also going to be part of the game changers that we're looking at. Every pregnancy counts.
Well, these are encouraging statistics in the fight against maternal mortality, indeed, Dr. Demby. Let's shift attention to, healthcare, the workforce, doctors and nurses. There is a shortage of qualified professionals, especially for overcrowded hospitals and those big referrals, for example, Connaughts, Of course, we're all aware that the Ebola outbreak, resulted to the loss of almost 21% of our workforce. In 2024, the country recorded a very low doctor and nurse density. The approximation is 1.4 doctors and nurses and midwives per 10,000, people. But this number is even slightly lower than the WHO recommended, which is 44.5, per 10,000 people. I just wonder, do these numbers worry you? And how can we get more people interested in medicine in Sierra Leone?
I'm very, very worried about these numbers. But worrying is one thing, is what do you do about it? Yeah. So when I got here, the number of doctors was about 500 for a country of 8.5 million. You need about 5,000 to 7,000 practicing doctors for this kind of population. So with 500 doctors, 600 doctors, half of them were administrators as well. You don't have the requisite doctor number, doctor to patient ratio. And so what they've been doing, or what the world has been doing, is what they call task shifting, where they train more nurses and they train more community healthcare workers to take on the role in more remote sites, but have not invested enough in medical training. Okay. With His Excellency the President's mandate to me, one of the #1 priorities is to increase the number of doctors. And it's not just increase the number of doctors, but to look at retaining them as well. So my colleague Alpha Wuri, who was the former Minister of Health, who was strategically moved to higher education, we had a pact. My first week on the job is, if you're training 30 to 50 doctors a year, and we need 5,000 to 7,000, you will need about 100 years to get the kinds of doctors that you have, provided nobody gets sick or nobody retires. So it's not tenable. So we have to renew our efforts in increasing the numbers, in increasing the skill sets, and not only training them, but also accommodating them. So there has been a deliberate effort here. So now we've moved from about 50 doctors. Last year, we graduated about 80 doctors. This year, we're looking at 120. Next year, it will be over 200 doctors being trained a year. They've been deployed in the districts. We were just in Moyamba district. They had 1 doctor before. They have an additional 4 now. We're sending about 8 to 10 doctors in each of the district hospitals as we turn them out. We're also not only investing in the current crop of basic doctor training, and by the way, we've opened a new medical school at Jala University to increase the numbers and complement what Commerce is doing. Okay. We're thinking longer term to perhaps look at McKinney as well as another option. But as we provide the doctors, we want to be able to see that there are opportunities for some to specialize. So 2 years ago, the President launched the postgraduate medical training for medical doctors and surgeons, for nurses and midwives, and for pharmacists. We're very pleased to see that the postgraduate residency training is really being effective. I don't know, a couple of months ago, we saw that Sierra Leone had 8 OBGYNs, obstetrics and gynecology specialists trained here. Yeah. They took the West African College of Medicine exams. They aced it, 100%. Yeah. 8 for 8. A lot of the other countries, if they have 50% or 30%, they're very happy. But we aced it, and not only aced it, but they were at the top of the class. And so these people are being deployed now. We're training more pediatricians, we're training more psychiatrists, we're training more surgeons. So the postgraduate school is actually at a very, very advanced stage. In fact, 2 weeks ago, the Vice President launched the groundbreaking for the postgraduate college, where we'll have the pedagogy as well as the administrative offices and the training facilities for our residents and our postgraduate doctors over at LACA. It is spectacular. We're supporting that. And also for the basic training, we're hoping that the Vice President will join us to look at how much progress we're making at the Dewey campus, where we're building a new facility for the students. As we speak, just last week, we received a big anatomage table.
Okay.
You know, cadavers are really hard to come by for the students. So we have an electronic cadaver table that allows you to mimic what you see. And it just arrived. We're going to install that. And as we train the doctors now, you know, it's not a light switch. You just don't say, we want the doctors, then it happens now. So we're training them. As we're training them, we're building new hospital facilities that will give them the tools to be able to practice their trade. So as we speak, we're building a new hospital in Moyamba, in Pujao, and in Karine. We have the funding that will start building an ultra-modern hospital over at Kerrytown. You have the Pediatric Center of Excellence over at Lumley. We have a brand new Maternal Center of Excellence that we're building in Kono that will be open at the end of the year. So on the medical doctor training, we're intensifying our efforts. We're increasing the numbers. We're increasing the diversity of skills. We're also increasing the tools that we have available for them. We just bought 2 CT scans for public use. We'll install one in Kenema and one here at Connaught. And we have a link with Columbia University to look at training Sierra Leoneans to be able to fully utilize these products and at the same time have backup on the diagnosis of them. So there's a lot going on the doctor's training, but we haven't, you know, a doctor by themselves is not going to solve all of the problems. We want to have a team effort. So having nurses in critical care nursing efforts, anesthesiology, in mental health services, we're growing that crop of them as well. We just opened a brand new midwifery school in Kenema that is sophisticated with a skills lab that's not been seen anywhere in the country. They even have their own radio station to engage with the public. So there's a lot going on in the health sector.
Okay, let's turn our attention to the all-time Kush, you know, Wahala, you know.
Yeah.
There is a huge border now on the Kisi mental home, you know, which is where most of these users end up, you know. Most of them, their futures have been darkened, but as they puff these smokes, you know, between 2020 and 2023, you know, the Sierra Leone Psychiatric Teaching Hospital recorded about 5,775 cases, you know, of psychoactive substance abuse, with 91% of those affected being male and most under the age of 34. As we walk past the streets of Freetown, we still see these people sleeping, you know, standing, sleeping in the streets of Freetown. And it's an eyesore, Mr. Minister. I haven't been hearing much from the Ministry of Health when it comes to, you know, the fight against Kush. We still have a state of emergency, is it, on drug in Sierra Leone? But not much is being heard, particularly from your own ministry.
So I think you're right, not a lot has been heard. I mean, we need to redouble our efforts, But the Kush situation, first, this country's focus is on young people. You know, it is the foundation of building a nation. The government's investment in human capacity development is a deliberate effort at investing in the next generation of leaders. So we can't afford to be losing this investment on a daily basis as a slow burning fuse right under our noses. The issue with Kush is not just a medical issue. It's a societal issue. So what the government has done is to pull together a multidisciplinary approach. You're not going to win the war on Kush if you don't have law enforcement involved in it. You're not going to win the war on Kush if you don't have social welfare involved. you cannot win the war on Kush if you don't have the pharmacy services involved. You cannot win if you don't have families and communities involved. So in declaring the war on Kush, it was a collaborative effort by all of these entities to come together to fight this. So again, some of the signs that you see out there are signs that is an overflow. It doesn't reflect all of the work that's been done, because there's one psychiatric hospital in the country, yeah. But the psychiatric hospital is intended to manage the worst of the worst cases, where you have psychiatric or schizophrenia or more complex issues in there. There's a need for basic clinical services to be offered to people as they have wounds and cuts and things like that. But then you need social services to be able to support them. You need religious services to be able to support them. So what you see is a combination of all of this at work. There's been a lot of apprehensions. There's a lot of arrests that's gone on with the manufacturers or the importers of what's going on. The social services have gone and created these halfway houses, rehabilitation homes. You know that the police, the training school up at Hastings is a major facility where we are identifying people who need help, who go in there and they're assisted, they're helped out. And when they're not only supporting them for their addiction, but they're also looking at their medical needs, but also you're looking at their social integration after they recover from this ailment. They're looking at assimilation of them. So my colleague in the Ministry of Social Welfare has been doing a phenomenal job in engaging universities, in engaging schools, in engaging work environments, in creating the safe space for these people to go back and be integrated. But it's a difficult situation. It's a difficult situation that has to have the whole country come together to fight it. And it's not unique to Sierra Leone. We're seeing it all over the region, and actually all over the world. We have Professor Fodesa, who heads the National Public Health Agency, is the coordination entities, the Kush ZA, so to speak. He brings all of these different entities together to work on this. So it's work in progress. Okay. We've made progress, but we're not there yet.
You know, earlier on you also mentioned, concentrating on, training more doctors and the need to have them specialize in some fields of medicine. How well are we doing in pathology or psychology in Sierra Leone?
Yes. So, as I indicated before, we need help across the board. Across the board. The other day we had one of the first neurosurgeons graduate, and he came back. He's in Connaught now. What you have is to measure the level of consciousness. It's called the Glasgow scale, and if you're doing very well, you're 15. If you really in coma, it's 1. So you have a whole range there. One of his first surgeries was able to move somebody from 3 to 15 in a day. So we have competencies and we have some deliberacy. I mean, it turns out in psychiatry, there's only one psychiatrist in the country, Dr. Naim. I think now we have about 3 or 4. We actually have faculty that is training psychiatrists. Dr. Jallo is heading the unit. I think we have about 2 or 3 Sierra Leonean psychiatrists now, and there's a long list of them that are moving into the space. For pathology, we had Dr. Owiz Kuruma as the only pathologist here for over 40 years. We're changing that narrative, and we have 2 Nigerian pathologists here who are faculty, who are training Sierra Leonean pathologists now, attracting them into that space. And the thing with our pathologists, we don't want them all to be here in Freetown. We want to be able to offer pathology services throughout the whole country. especially at the provincial level. So as we train, one of the critical things that we're looking at is you don't train for training's sake. If you train and you don't provide the services for the people, they're marketable, they will leave as soon as they finish their training. So what we're doing now is to ensure that as we train, we're providing the environment for them to practice their art. So the pathologists are in queue for training, the psychiatrists are in for training, all of the different disciplines are in for training. And it just turns out in Sierra Leone, I am not surprised when people say we're one of the smartest in the world. Because every time you give somebody an opportunity, they excel. They excel. And so what we want to do now is as we train them, we move them out of Freetown, because Freetown is not Sierra Leone and Sierra Leone is not Freetown, but to be able to offer these services across the country. What we're doing, for example, in Kono, if you have time, you should really swing by there. We have a workforce that's building one of the most sophisticated hospitals in the region. This hospital is built, 60% of the staff in the construction site are women. What they're saying is, we will build a hospital for us women. This hospital will be built on an e-platform that is linked to Harvard University and University of Kigali. And it'll focus on OB/GYN, obstetrics and gynecology, and pediatrics. And right now, in fact, all of those 8 people who went out to the West African College of Surgeons journeyed through Koidu Government Hospital, and they're going to have this new facility. So a lot of the young doctors are going to hope to train in Kono than they are in Freetown. So again, it's spreading it in the country.
And when it comes to service delivery in these, hospitals or clinics and the likes, how does your ministry as well carry on with monitoring and evaluation?
Yeah. So what has happened, Sierra Leone was the country that read the Alma Ata Declaration that launched primary health care as the major form of healthcare delivery in the world. And the principle behind it is to take healthcare as close to the people as possible. So what we've done over the years, over the past 45 years since Alma Ata, is to focus on primary healthcare and take healthcare as close to the people as possible. What we haven't done equally is to invest in the hospital services. So what I'm doing now is making sure that we double down on the success of primary healthcare as you take healthcare to the people, and complement that with the secondary and tertiary care, and invest in referral networks between the two. So going forward, we have about 1,600 facilities that are offering services, healthcare services in the country. And it means that 85% of the population has a facility within a 5-kilometer radius. The challenge we've had now is, as we're creating this access, is to equally invest in quality. So my responsibility now is for those 1,600 sites to bring quality to them. And we look at quality in 4 major domains. Number 1 is infrastructure, ensuring that this place is clean, is tidy, it is attractive, that people want to go there. We want to be sure that they have electricity. We're moving away from generators and thermal electricity to ensure that all 1,600 of our facilities transition to solar energy. Right now we have about 350 of them, including major hospitals, have transitioned to solar energy. We're ensuring that the solar energy doesn't only provide light, it provides energy for running equipment, and it also allows us to provide water, potable water, on the facilities. The second area is staffing, ensuring that you have the right complement of staff, the right number of staff, and the right attitude of staff to provide services. So we have infrastructure, staffing complement. The third is supply chain, ensuring that products are available, accessible when you need them, and how you need them, and stored properly. And the fourth is drugs. So for all of the 1,600 facilities, we are aggressively pursuing that district by district, site by site, to see that we meet these metrics for them. It's work in progress. We're not there yet, but we're gradually moving in that right direction. What we're also doing is that for the 1,600 facilities that were conceived years ago, you have demographic shifts. Villages are becoming towns, towns are becoming cities, lumas are just popping up everywhere, and the population is shifting around. So what we want to do is to look strategically, where do we provide these new facilities that we're looking at that will provide services for a bigger catchment area. And we are targeting extending the 1,600 to 2,000. So all of our planning around energy, around staffing, around supply chain is looking at 2,000 facilities between now and 2030. So it's ongoing, and there is intentionality about what we're doing. There is progress being monitored. And in fact, I don't know if you've heard, but we have this spotlight of the districts that just started. We're going district by district. But the president said, you can't run healthcare by sitting in a UU building. Yeah? I want everybody to go out in the field and see what's going on. So we started at Moyamba. All the directors, all the managers are going into Moyamba and work with their counterparts, the district health medical team, the hospital team. We're going to look at every aspect of service delivery, from the hospitals to the clinics, to staffing, to supply chain, to drugs, to public perception, to public engagement. And we're complementing that with those hospital on wheels. Mm-hmm. The hospital on wheels have been a tremendous success. Men don't like to go to the hospital. You only see them when there's trauma, when they fall off the motorcycle or they have a heart attack or something. Women are always in the hospital for themselves and their children. But when this boss shows up, everybody shows up. And we're seeing a lot of things that are happening within the community that you don't normally see in the hospital. So it's giving us a public perception of what's going on, so we understand better what the healthcare needs are within the community at the district level. So we're going district by district. We're spending 30 days in every district. And the first district in Moyamba has just been phenomenal. We've learned so much. In fact, yesterday, all of the DMOs, the district health medical officers, were in town, and we're debriefing on the Moyamba experience. And the idea is, you don't want to wait till we come to you. You could learn from what we see in Moyamba and start improving, so that by the time we get to you, you would have solved all of the problems that Moyamba had been dealing with. So it's very exciting. It's a national effort. I am confident that a country this size, a country with this kind of population, we should be able to take care of our healthcare needs, not at an individual level alone, but at a societal level. And the president is very clear, we're using health as a platform for our nation's development. And the cool thing about it is also we're looking at these health facilities and supporting the health facilities, supporting the health clinics, supporting the doctors. But that in itself is not health. Health is a compact between the facilities, the providers, and the people. So for example, when the bus goes, we're looking at people's blood pressure. There's some cases where people have extremely high blood pressure in the community. They don't go to the hospital because they don't feel sick. They just say, I feel bad no more, you know. But wait a minute, if you have high blood pressure that's not managed and you don't go to the facility, by the time you get to the facility, it's a stroke. By the time you get to the facility, it's a kidney failure. By the time you get to the facility, it's blindness. So going into the community now and working at the community level to identify these risk factors and work with the community to address them before it needs to come to the hospital is very vital. Again, just with this high blood pressure, we're seeing communities with 30% where the bus is going. Again, this is not an indication of the community because it's a self-selected people. I mean, I don't feel too well. Let me go check the bus don't come. You have about 30% of them with high blood pressure. Well, here we have an opportunity to say, look, let's go into the community. We could manage high blood pressure by lifestyle changes. You know, like it's that strong cassava leaf and rest and continue rest at 10 o'clock at night because the body is not able to metabolize it. It just stores it. You gain weight. You cannot have this extra Maggi because they make the thing sweet. You put extra salt in there. You elevate your salt level and the blood pressure goes up. You cannot manage your blood pressure by sitting at home everywhere you go, keke or bike or vehicle or whatever, without moderate exercise. So our elevator doesn't work so often at UU building, but I run up the stairs every day as my exercise. So with a little exercise, managing your salt intake, managing your diet, you are doing 60% of what it takes to manage blood pressure. And if we do it right as a community, we'll reduce the pressure on the hospitals. So I think what we're looking at is, let us not take healthcare as hospital business. It's something that we could do, we could contribute to, and it's a partnership between us and the community we serve.
You've just given vital information, but I'd want to ask, how accessible is this to, ordinary Sierra Leoneans out there? How does your engagement with the citizens go like?
That is something we need to work on. Again, it's a mental shift because, as I said, everybody thinks healthcare hospital, healthcare hospital. We have to be able to ensure that when somebody shows up at the hospital, they get the requisite care. So we're working on that. What we're doing now is go beyond that and go out to the people. So this kind of engagement, for example, I told you that the school we have in Kenema has their own radio station. The radio station there is to be able to reach out to people and answer that question, give health information, give health guidance to people, inform them about how they could help themselves for their own health and for the nation's health. So again, for all of these things, there is intentionality, there is deliberacy, there's interest, but we're moving in that direction.
There were health clubs in schools before now. Do we still have them?
Yes, yes. So I think so for example, we've shifted focus. Again, that's one of the really revolutionary things that are going on in this country, that every other country is like looking in to see what we're doing. We're shifting focus from a disease-based healthcare system into a person-centered care. Because I may be sitting here, I need malaria services, I need HIV services, I need to manage my blood pressure, I have diabetes, I have to manage it. So you cannot come at me as malaria program, TB program, HIV program. I want to be the center of service delivery. So we're shifting the mindset of our providers to look at patient-centered care. And the other aspect of it is, how do you do it for everybody? Instead of just looking at who shows up in front of you, we're following life stages. We're looking at the pregnant woman as a cohort. We're looking at the baby from 0 to 6 as a cohort. We're looking at preschool. We're looking at school health. We're looking at young adults and senior citizens, because they each have different health needs. So that's the approach we're looking at, life stages approach to healthcare delivery. And we're looking at person-centered care. So some of these interventions, for example, you're talking about health education, health promotion. The idea is to have every component of our society engage in this. The messages for pregnant women are different from the messages from a child, from a teenager, or from an elderly person. So by actively engaging in not health education, but health promotion, because we want to give you the information, but we also want to influence you to change lifestyles to be able to get the health benefits associated with it. So it has to be done across the board, with pregnant women, with children, in schools, with adults, and with senior citizens.
Dr. Demby, we'll finalize on this because you spoke about person-centered care, which I feel is quite crucial. You know, another thing we've overlooked of late is the increasing rate of people who smoke shisha, for instance, which is even more harmful than tobacco. A lot of people don't know this because of the flavors. They get enticed, to smoke them. The increasing rate of carbon emission, contribution towards cardiovascular diseases, for instance. Everywhere you turn now in the city, there are some sort of dump site that is burning, these road unworthy trucks that spew thick black smoke in the air and all of these things. And that is even wrong to eat rice in the morning, in the afternoon, and bread at night, very late at night. You touched on that earlier, I don't know if there is a particular mechanism, let's say television commercials, for instance, investing in that. Maybe the ministry would create a branch that will perhaps go towards public health, education, that it is wrong to do some of these things. Because, so be honest with you, a lot of people don't know these things, you understand. Access to knowledge is very low in these areas.
So you're right about that. I think there has to be a concerted effort at public education. Like I said, the public is perhaps one of the most powerful partners in healthcare delivery. Nobody wants to be sick. Nobody wants their relative to be sick. And so if they know the right thing to do, it will contribute immensely to their decision making. For example, there's an anti-tobacco law in this country. We're looking at its enforcement. And we need to aggressively go out and, it says that you cannot smoke within 3 meters of anybody. You're right, the shisha thing, these people are extremely smart. Nicotine is addictive. When you put flavors in it, you want to catch them when they're young. When they're young and they catch that, it's a lifetime commitment already. It is terrible. The health consequences of it are just unbelievable. First we have some of the laws that are in our books, we need to enforce them. But as you're right, we also need to go out and inform people. Give them the information that this shisha that you're smoking may be cool, but look at the consequences of it. Emphysema, over the years, you have the cancers, you have all kinds of complications. Asthmas are aggravated, and people don't know that. And they sit there and think it's cool to do the shisha thing. I think we need to aggressively pursue it. Just the smoking part, it's not just harmful for you, the individual, but even the people around you. The passive smoking is nearly as deadly as the smoking itself. We cannot let just the laws be there, we need to implement them. And you're right about information. When we grew up, there were programs, there were health programs that talk to people in the local languages about their health. And honestly, if I know what I need to do for my health and for my children's health, I will do everything for it. I think what we need to do is to shift gears and invest a lot more in that. So it's not just the doctors and the nurses and the hospitals. We need to invest in public education, in bringing the public along for their own health. I learned that during the Ebola outbreak, because I think it's really simple to sit there and say, oh, they don't care, they know this, they know they do the right thing. But we haven't told them. If you take the time and explain to people what's going on with their health. At cabinet, every time we talk, I bring the Maggi. Everybody laughs, hey, that's what's Maggi. But Maggi is monosodium glutamate. It's one of the most toxic of salts that you can imagine. It gives you flavor, and I think it's important for people to have flavor, not have bland food. But you could have moderate quantities of it. because the more you have, the more it allows the heart and the blood vessels to work too hard, and that's how the pressure builds up. And until you reduce the salt intake, it's not going to work. So it's not something that will change overnight, but constantly explaining to people. Normally you put 4 Maggi, maybe we'll make 2 force, make 1, we reduce 2 to half. It gives you the flavor, but not give you the health consequences of it. You're right. We will aggressively look at working with health promotion, working with media, and there are all of these radio stations around the country. And for people that have access to TV, these are important interventions we could collectively add to the knowledge base that will help secure our health.
Quickly, as we try to wrap up, I want to ask about how far are we with traditional medicine in Sierra Leone?
Yeah.
For some countries, they have traditional medicine incorporated into the health system.
Yeah.
And for maternal and child health, which you mentioned, there's also incorporation of the traditional birth attendants, which also goes to show that they are important and their knowledge is needed within the health system.
Yeah.
How far are we with that?
So traditional birth attendants and traditional medicine is vital to our nation. Yeah. I would guess that over 90% of the people, when they have a health need, they go to the traditional healer first. And when things fail, that's when they come to the hospital. What we know is that they're extremely good partners, but they have to know the limits of their skill set. You could have medications that they know work, but it's all a dreamer. We don't have the empirical evidence to show that this actually works. So engaging with them, trying to understand these things and help them with validating some of these interventions, because I will get this one man men belly aches, it men headache, it cure you asthma, it cure cancer. It's not right.
And there's little or no research that has been done on that.
Hardly any. I would say close to zero. So, but they play a vital role. What we want to do is to create a partnership with them more as a psychosocial support and referral network, so that if somebody comes in, you review them and say, let me send you to the hospital and let's see what happens. After you finish your hospital thing, you want psychosocial support whilst you're there, I'm there to help you out. But not the clinical care, because we don't have evidence of the effectiveness of it. But that's our tradition, that's where people go. So it's important to work with them as partners. So I know they have several associations, and we're working with these associations to codify them, to regulate them, to see how we could support them going forward. With the traditional birth attendants, it's a special case. We encourage them not to deliver babies, but to be there as support. Because what happens is people tend to deliver at home with the traditional birth attendants. A huge percent of the mortality, the maternal mortality, occurs in that space. Because when you try to deliver at home, simple problems like the baby's hand comes out first, how do you manipulate that? You have an emergency, it's very likely that the baby will die and the mother will die. So our engagement with the TBAs is to provide support, to provide assistance, to give confidence to the pregnant woman, but leave the mechanics of actual delivery and care to the hospital services. So we're encouraging 100% hospital-based delivery, because anything that goes wrong, if we need to have a C-section to take the baby out, we will do that safely. If there's complication, we'll do that safely. If there's hemorrhage, we'll block the hemorrhage. In fact, we have a new drug that's available to us, the heat-stable cobitocin, that normally they use oxytocin to help with delivery. they hit comatose. The anecdote that we hear is the cleaners in the clinic come around and say, then deliver one blood not in the gun. It is so effective and it's heat stable. We could use it throughout the whole country as part of the arsenal. But we work closely with the traditional birth attendants and leaders in a social support way, but not in fact, it's illegal for them to deliver at home. We want all of the deliveries to occur in the hospital. And we begin to see the outcomes associated with that. That's how you see this maternal mortality is dropping. Survival rates are dropping, are increasing. And you see also the number of natural multiple births are successful. We're delivering quintuplets, now we're delivering twins on a regular basis, triplets on a regular basis, without any extra help, just using the services that we have. But let it be in the hospital. And the other thing that we want to do is, for pregnant women in particular, we don't want to wait till the last minute. So the TBAs could be extremely helpful as support staff. As soon as that pregnancy is registered, you ensure that you come to the hospital for your regular visits. If you have the high blood pressure, we'll manage it. If you have diabetes, we'll manage it. If you have HIV, we will treat you and manage you such that it's not transferred to the baby. So the earlier we engage, the greater the success of it. And with this new app that we have, we will track it. If the pregnant woman doesn't show up for an appointment, we know that they didn't show up for the appointment. We'll go and meet them. Either encourage them to come or have the nurse go visit them. There's going to be a proactive engagement, and we'll see the results go down even further. I don't want to announce results here, because as soon as we begin to say, hey, but now then don't fix the numbers, let UNICEF, WHO, let others come and look at the data and tell us what we have. But I'll tell you something, the numbers you saw were 2023. Wait till you see 2024 and 2025 numbers. Okay. You're going to be impressed.
Thank you very much, Dr. Austin Demby, the Minister of Health, for making it to our show this morning.
Thank you.